We are going live in 5, 4, 3, 2, 1. We are live now.
Okay. I think we are live now. Thanks all and for the master series on shoulder. This is what we are doing organizing pan India, and it has become a pan global event. And today we have one of the masters in shoulder himself from Japan, Tohoku University. And it's a little more special event that I was privileged to have been trained under him. So it is, I could say, he was my boss. So it's always great to moderate your own boss. Not many get an opportunity, and it's great I've got an opportunity for that itself. And about a small introduction about Professor Yamamoto. Of course, no one needs an introduction, but as a duty, as I'm always privileged as a shoulder surgeon of the global community to give a small intro. He is a professor and a consultant in the Department of Orthopedics in Tohoku University since 2009, and along with Eji Etoy, and now I could say he is about his literature and his publications. I really can't keep a count of them, but just to put a number to that, I always keep telling him it grows more and more day by day. But one thing, he never goes old. So even now he looks younger among the all of us in the community. So I think to number few, more than 130, 40 publications with original articles and textbooks, more than 65 plus chapters. And I could say a 2-digit or 3-digit number for reviews, and apart from that, he is a global faculty, and we all know him for one specific event on glenoid tracking. I think this is one event that has changed the course of shoulder surgery. The way we have started looking at instability and started working on instability has totally changed. And it is nothing more privileged or honored to have the talk by the master himself. Now, again, I would also extend to my sincere thanks to Dr. SenthilVelan, who is the clinical head and of the upper limb and shoulder department from MIOT Hospital, Chennai. And I really thank to take a small break from his busy schedule and help us moderate this wonderful academic bonanza. In today's event, we are going a little early than live. I think we have got a little more time to discuss with the master himself and a little more questions to take on. I would pass it on to Dr. Senthil for a few words, and then we can start with the professor's talk.
Welcome, Professor Yamamoto, and thank you, Dr. Karthik and OrthoTV for providing this opportunity. It is really, really an honor to actually, have Professor Yamamoto on our talk. And as Dr. Karthik already mentioned, this is a shoulder series, and today's talk is on the glenoid track and by the master himself. And without much further ado, we will actually proceed to Professor Yamamoto, and we'll have the talk by him without any interruptions. Then we will actually pose questions and also at the end of the talk. Over to you, Professor.
Yeah, please. The dais is on yours. We're happy to hear you.
Okay, so let me share the screen. Can you see my screen?
Yes, we can. We can.
Okay. I'm Nobu Yamamoto from Tohoku University. It's my great honor and great pleasure to talk about the Glenoid track. And I came from the Sendai, and the Sendai is located north to Tokyo. It takes 1.5 hours from Tokyo by bullet train. And the population is 1 million. And 2 weeks ago, we already had a snowing in this area. And my university hospital was built in the 1915, and we have 1,300 beds. This is one of the oldest hospitals in Japan. So today I'd like to talk about two topics. One is measurement of the glenoid track, and the second one is peripheral track lesion. A large bone loss is known to be a risk factor for recurrence, and the incidence is very high. Glenoid defect, 86%, Hill-Sachs lesion, 94%. And the bipolar lesion is a combination of the glenoid defect and the Hill-Sachs lesion. Its incidence also very high, 81%. When considering treatment of the glenoid defect, we just think about the glenoid defect because it is related to the mid-range stability. In the mid-range, we just consider only the glenoid defect. However, when considering treatment of the Hill-Sachs lesion, we need to consider the bipolar lesion, both lesions. For example, in this Hill-Sachs lesion, it's safe because it's located between contact area. However, if there is a glenoid defect, engagement occur. So we need to think about the bipolar lesion. We have proposed the concept of the glenoid tract. Glenoid tract is a zone of contact between humeral head and the glenoid. The width of the glenoid tract was demonstrated to be 83% of the glenoid width in vivo MRI study. We have think about the glenoid defect separately, but by using the glenoid tract concept, we are able to evaluate both lesions at the same time. My friend Giovanni Giacomo developed our concept. He named engaging Hill-Sachs lesion off-track lesion, non-engaging Hill-Sachs lesion on-track lesion. So how to measure the glenoid tract? We recommend to use the 3D CT. Just hanging position is fine. We don't need the abduction and external rotation position. First, we should use the complete posterior image. But which one is a complete posterior image? To find the complete posterior image, first check the axial image, and then image is rotated by 90 degrees like this. Next, find the medial margin of the footprint. It's easy. But some doctors said it's not easy to draw a line of glenoid tract. For example, in this shoulder, which one is a cartilage edge? Sometimes it's difficult. But we recommend to find the intersection of the humeral head cartilage and the greater tuberosity. Here, this mountain. Then we can draw a line glenoid tract along the cartilage edge correctly. In this shoulder, here you can see the mountain. In this shoulder, this one. Next, the glenoid width of the uninvolved side is measured. For example, in this shoulder, 20 millimeter. So glenoid tract can be calculated 20 times 83%, 17 millimeter. So from the major margin of the footprint, glenoid tract width is 17 millimeter. So we can draw a line along the cartilage edge. Then this Hill-Sachs lesion located within glenoid tract, it's on-track lesion. It's safe, we don't need the treatment. Some doctors said CT is not available in my hospital and also we should avoid radiation exposure. So these days, some surgeons recommend to use an MRI image to measure the glenoid tract. In their method, in sagittal image, first they measure the glenoid defect, and then using the axial image, they measure the distance from the footprint, which is called the Hill-Sachs interval. This MRI method looks easier, but my question, is it accurate? Then we compare the MRI method and the CT method. 32 cases were involved in this study. Here result. In CT method, 7 cases are judged as off-track lesion, whereas in MRI method, 10 cases. So there are 3 mismatch cases. There are 2 reasons. First one, in CT method, The distance was measured in a plane perpendicular to the cuff attachment, like this. But in MRI method, they always use the actual image. So glenoid tract width measured in the MRI method is different from the compared to the CT method. So glenoid tract width measured in the MRI method is always longer compared to CT method. Second reason is glenoid defect size is different. In our study, the glenoid defect measured in the CT method was 2.2. On the other hand, in MRI method, 3.3. It's always greater than that measured in the CT method because their measurement method is different. In CT method, we always use a comparison method, but in MRI method, they use a best fit circle method. The measurement of the bone loss should be accurate because in this shoulder, the glenoid width is 24 millimeter. 6 millimeter is equal to 25%, 2 millimeter 8%, 1 millimeter is 4%. So we are measuring a very small word. If you use a 3D CT the image, we can clearly understand where is the margin of the glenoid. But if you use the MRI image, sometimes it's very difficult to detect the, differentiate the cortex and the labrum like this. That's why we recommend to use the comparison method compared to the involved side and involved side. And largely reported, the comparison method is superior to the best fit circle method because higher intra and inter-observer reliability. That's why 3 cases were overestimated. MRI method looks easier, but it may overestimate off-track lesion. The width of the glenoid tract was 83% of the glenoid width. We are using this value, 83%. But this is the mean value. In our study, 30 healthy volunteers were investigated, and the range of glenoid tract was 71% to 95%. It's wide range. Because glenoid tract depend on the range of motion. Glenoid tract is a zone of contact, so if the patient has a stiff shoulder, glenoid tract width increase accordingly. On the other hand, if the patient's shoulder is a loose shoulder, glenoid tract width decrease. So we need to consider the joint laxity, and the joint laxity is related to the range of motion. For example, in this patient, external rotation is 30 degrees, so joint laxity is like this. But in this shoulder, 80 degrees of external rotation, he has more laxity. So greater range of motion means joint laxity positive. We investigate the relationship between range of motion and glenoid tract using fresh cadaver. Then our data shows glenoid tract is affected by horizontal extension motion most. We confirmed it in vivo using MRI. 41 shoulders were investigated in this shoulder. Various range of motion were investigated in the sitting position and supine position. Among them, horizontal extension in the sitting position shows the greatest correlation coefficient. So our data showed horizontal extension is the key to calculate the glenoid tract width. We propose a glenoid tract table showing the relationship between horizontal extension angle and glenoid tract width. For example, in one shoulder, his horizontal extension angle is minus 10 degrees. His glenoid tract width is 95%. 0 degrees, 90%, 10 degrees, 85%, and 20 degrees, 80%. So if we use a glenoid tract table and you know the horizontal extension angle, we are able to know the individual glenoid tract width. So in the sitting position, we just measure the horizontal extension angle of the uninvolved side, not the involved side, because the patient feels a dislocation feeling in this position. Then we are able to know the individual glenoid tract width. Second, I would like to talk about the peripheral tract lesion. It is well known dislocation position is abduction and maximum external rotation. It's true, but not always. In fact, in many cases, dislocation occurs at the mid-range. In this judo player, she had a dislocation with the arm 45 degrees of abduction. Video analysis by Crichton reported among 16 rugby players, 8 dislocator greater than 90 degrees elevation, 3 dislocator horizontal abduction. Subclinical bone loss is related to the mid-range instability because in the end range, ligament contributes to stability, but in the mid-range, ligament is lax, and main stabilizing mechanism in the mid-range is concavity compression effect. Humeral head is compressed to the glenoid concavity by rotator cuff muscles. Surgeons have a focus on the end range. In the end range, if there is a buccal lesion, shoulder is stable. But after buccal repair, shoulder became stable. But in the mid-range, even after scopic buccal repair, stability does not increase in the mid-range. And in the mid-range, even patient has a large defect, greater than 25%, shoulder is stable because ligament contributes to stability. On the other hand, in the mid-range, if there is a large defect, dislocation occur. These days, just below the critical site is called subcritical bone loss. This is proposed by the Turkish group. Definition is no dislocation but clinically decrease in QOL. We investigated this and we performed the clinical study of the 43 shoulder who underwent scopic buccal repair. All patients had a less than 25% glenoid defect and WOSI score was investigated. Our data showed the bone loss between 70% and 25% was subcritical bone loss. Why decrease in QOL without dislocation? If patient has a subcritical bone loss in the mid-range, during motion, even concavity compression effect work. During motion, micro-instability may occur. So the QOL decrease, especially in patients with high activity. We apply this subcritical bone loss concept to the heel-sac lesion. 83% of the glenoid width is borderline between on-track and off-track lesion. But how about this? 82%, just below the 83%. Can we perform the scopic buccal repair? To answer this question, we performed the clinical study of the 50 shoulder who underwent scopic buccal repair. All had an on-track lesion, and WOSI score was investigated. The distance from the major margin of the footprint to the medial margin of the Hill-Sachs lesion was divided by glenoid tract width, which was defined as Hill-Sachs occupancy in this study. With this Hill-Sachs occupancy defined as 100%, which was divided into zone 4, 1 to 4. If Hill-Sachs occupancy is greater than 75%, in their WODI score, the zone 4 was significantly decreased compared to other zones. WODI score composed of the 4 domains: physical symptom, sports recreation work, lifestyle, emotion. Among these, physical symptom domain decrease, and for example, patient complain difficulty in elevation motion and instability feeling. 83% is borderline between remplissage and latarge and scopic buccal repair. This is critical bone loss. But subcritical bone loss is 75% of the glenoid tract. And there was no correlation between QOL and Hill-Sachs occupancy. Even on-track lesion, if Hill-Sachs lesion is located more than 75%, their QOL decrease, so they need treatment. We call this Hill-Sachs lesion peripheral tract lesion. On the other hand, if Hill-Sachs lesion is located less than 75%, no need for additional treatment. We call this Hill-Sachs lesion central tract lesion. On-track lesion divided into central tract lesion and peripheral tract lesion. So which surgical procedure should be chosen? For central tract lesion, scopic buccal repair is fine. On the other hand, peripheral tract lesion, scopic buccal repair, remplissage, latarge, they're a gray zone. There are 2 points. The first one, we need to consider the glenoid defect. If patient has a small defect, less than 17%, we don't worry about bone loss. Just scopic buccal repair is fine. However, if patient has a large defect, greater than 25% critical bone loss, we need bone grafting such as latarge procedure. If patient has a subcritical bone loss between 70% and 25%, remplissage or latarge procedure. Second point is we need to consider the risk factor. Our data showed risk factor are male and contact athlete. So if patient has a peripheral tract lesion, young male with high activity and participate contact sport, it's high risk. So we should perform the latarge procedure. But if patient is a female and low activity and non-contact athlete, it's a low risk. So just scopic buccal repair is fine. But we are not treating the bone loss. We are treating the patient. So many factors related to the patient. So factors are age, sex, dominance, type of sport, contact or non-contact, sport level, activity level, job, combined lesion. Among them, our data shows age, sex, activity level, and contact or non-contact. So next topic is a similar concept reported these days. Dislocation to distance, DTD, near track lesion, and the HG ratio. DTD is a distance from the medial margin of the Hill-Sachs lesion to the glenoid tract. If DTD decrease, the value reported its rate of recurrence increase. Also, DTD is less than 8 millimeter. Due reported it's predictive of failure of the scopic buccal repair. They named this Husac lesion near track lesion. And they proposed the glenoid tract should be viewed as a continuum rather than discrete on-track, off-track entities. But I had two questions. Is glenoid tract measurement using MRI accurate? As I said before, MRI method may overestimate, so it's not accurate compared to CT method. Second question is, glenoid tract can be a continuum. With the increase of glenoid defect, WODI score decrease because there are correlationship between glenoid defect and WODI score. In the mid-range, glenoid defect is related to the instability. So for glenoid defect, we can consider it as a continuum. In the end range, but we need to consider both region, Hisaku region and glenoid defect. And our data shows there was no correlation between QOL and the peripheral tract lesion. So second question is no. So let's compare near tract lesion and the peripheral tract lesion. For example, in this shows the glenoid width is 25 millimeter. Glenoid tract can be calculated 25 times 83%, 21 millimeter. Peripheral tract lesion is 25 times 75%, 19 millimeter in this shoulder. Here is one case, 21 years male, glenoid tract line is 21 millimeter, and the peripheral tract line is 19 millimeter, and the near tract line is 8 millimeter. If you choose the peripheral tract lesion concept, this Husac lesion is a central tract lesion, so no needs treatment. However, if you choose the near tract concept, this needs treatment, so we may overestimate the off-track lesion. How about HG ratio, which is defined as Husak's interval divided by glenoid tract width? And the Yang reported HG ratio greater than 0.7, an increased risk of recurrent instability. HG ratio and Husak's occupancy, these are the same parameter. And their value, HG ratio 0.7, and our value, Husak's occupancy 75% is very similar. It looks very similar, but they're not same parameter. Because HG ratio, they are talking about dislocation. But in the study, Husak's occupancy, that's a subclinical bone loss, and no dislocation, but QL decrease. So it's not same. In summary, subclinical Husak lesion is called peripheral tract lesion. Glenoid tract measurement should be used by the 3D CT rather than MRI image. Near tract concept, if you use, you may overestimate. HG ratio is not the same parameter as a Husak's occupancy. Thank you for your attention.
That was a wonderful, I would say, rather mesmerizing talk, Professor, as usual. That one thing I always get amused about you, you're always very clear in your concepts, and you always guided me towards the correct line when it comes to choosing a patient. Again, we have also got a gift indeed. We have finished the talk earlier, so we can trouble you with a little more questions if you don't mind.
Okay, good.
Just to start on the questions, Professor, I think we started shoulder surgery, learning it about the glenoid tracking, and now we have advanced to peripheral tracking. Now again, started to understand the periphery, the near track concept. Now, for example, as you rightly told, the near track is of overestimating. In a peripheral tracking, the zones are divided. Zone 1, 4, and zone 4 is the peripheral zone. If we are looking at a peripheral track Hill Sachs, let me categorize as two example patients. A young guy, not much of bone loss with remplissage, a peripheral tracking remplissage. One, a normal population guy. Another one, a sports guy, more into, as you rightly told you. Would you still go ahead doing a remplissage in a normal white collar job patient, considering him in the peripheral track lesion?
Yes, that's good, very good question. Still, the treatment of the peripheral tract lesion is a gray zone. I prefer to perform the lamp research in normal guy, but if she's a female and low activity, just a bunker repair is fine. But high activity, the young male, we should add lamp research or lateral procedure. But these days, I prefer to perform the lateral procedure because we can get good stability even in the mid range. And if you choose the lamp research, and we cannot expect the increase of the stability in the mid range, not end range. There are some report and clinical report, but there are no evidence of the biomechanical data. If we add a lamp research, we can get stability increase in the mid range. That's why I prefer to perform the lateral procedure for this population.
Thank you, Professor. I'll give it to Sendai.
Excellent, Professor. Uh, again, it's excellent talk, and you have simplified the concept and talked a lot about it. And we still, I'm recovering from the talk. But I have a few questions. One is we talked about the overestimation of the glenoid tract with the MRI. And obviously, you already shown in your papers that actually using a contralateral normal CT would actually be a more correct way of determining the track. So, what is your opinion? Because in a lot of patients, they do have apprehension about the radiation exposure of bilateral CT. But in our institute, we follow your method, bilateral shoulder CT. But my question is a bilateral shoulder MRI would be an alternative? Do you think, in your opinion, that whether even if you actually compare a normal MRI, would that be a method to actually go ahead in the future? What are your thoughts, Professor?
The you know we need a contralateral side, but if you choose the MRI, you don't need the contralateral side. Just we measure the Hughes interval in their method. But yeah, many people they pointed out radiation exposure when taken in a bilateral side, but it's not true. If you take one side or both sides, now we are using a multi-helical the CT. Always both sides are involved. The radiation exposure is the same, even the one side and both sides. We don't worry about the radiation exposure. It's same. And that's why we recommend the CT method. If you choose the MRI method, of course, no radiation exposure, less expensive in Japan, but it's not so accurate compared to CT method. That's why we recommend using the CT method.
Thank you.
That's a wonderful answer, Professor. Again, for a next question, again, slightly deviating from, I think one you have enlightened to our audience is to understand the basic difference between mid-range instability and end-range instability. I think that is a very deceptive concept, but needs to be very clear on that. In nutshell, the end stage is most of soft tissue and the mid-range is more of a bony instability. So when it comes to this magical number, which I still remember those days, I was always asking you about the magical number. So there are, if you look at the global numbers, Like the numbers are dropping down day by day. It started with 25, 20, 17, as you rightly told, 13.5. And now when I was speaking to George Atwal the other time, he was saying I've started doing latages for 10% bone loss. But I'm still happy you're still in 17. So what would be your magical number in a general population and in a population which is athletic?
For a
Yeah,
latter.
that's also good. Yeah, good question. The value of the critical is dropping year by year. But
Especially when we go to the French side.
yeah. But yeah, this stage and we focus on the just dislocation before. Dislocation means the engagement also involved. But this days now we focus on the QOL, not just dislocation, but QOL. Then the patient feels something, the dislocation feeling. So it is related to subclinical bone loss. So the concept is changing. We used to consider the just dislocation, but these days we focus on the QOL, ADL. That's why the threshold is decreasing. But I think not 3% or 5% critical threshold. I think 70%, 50% is probably the minimum. I hope so.
Sure. And Professor, regarding the glenoid track, obviously, you've already mentioned that it actually varies with the position of the patient. It depends on whether the patient has stiffness, whether the patients have, pre-existing morbidity. Do you think there would be geographical variation across? Because the reason why I asked this is that the micro instability, what you described, and also the bone loss, that kind of patients, with the amount of bone loss in India, we don't see the 30% bone loss that commonly. We see the 5%, 6%, but we do see a lot of patients having what you are now describing, as the micro instability, where they say, I've not had frank dislocation, but I'm having pain. I'm not able to do what I want to do. I can't get to sports, but they don't have a frank dislocation. So do you think there is a significant geographical variation to how we should be treating these patients rather than as a general rule?
Yes, and many factors are related. We need to think about, the sex and also joint laxity, range of motion, the sports activity. Many factors we need to think about. Those are related to the shoulder stability. But now we performed the study, but still, the many factors are not unknown. So we need further data, especially I think the joint laxity and the Glenoid bone loss and the sports activity is a main factor related to shoulder stability. So that's already clarified from our data.
Thank you.
Thank you, Professor. As I always keep asking you, we are also on a battle about this remplissage. There is still a group. I think it's become accepted now that there are a group of surgeons who do remplissage as a routine with every bank cards, irrespective of tracking. And there is still a group that remplissage has to be titrated and seasoned. I know obviously you would support, being the inventor of the tracking itself, to look into it. What is your take on blindly adding remplissage without looking at, I mean, for even a on track lesions? Or have you seen the clinical aftermaths, or you feel it is really helpful, or what is the take on that, Professor?
Yes, and remplissage is very simple and easy to do. But and many surgeons there are the remplissage in addition to the bunker repair, and for me their indication is too much, and I'm concerning if the patient is very young, and we are performing the footprint is more medial if we perform the remplissage. In the long way, 10 years, 20 years, I'm worrying about the impingement and resulting in the articular side of the tear. So we need to consider the long-term result after lampreyage. So I think the indication for lampreyage should be more narrow. Now many doctors perform the lampreyage very frequently, but we need to check the the cuff, the condition after lampreyage 10 years, 15 years later. Yeah, that's my concern.
Sure. Uh, And Professor, there is I know with Professor Itoy, this is slightly deviating from the topic, but I would like to ask you about the external rotation braces because you've done a lot of work on that, but in it was unfortunately not replicated and it has not been taken up in the whole wide world. But relevant to this particular topic, your thoughts on so do you think like an external rotation brace, obviously you showed from a lot of MRI studies that the labral tissue does oppose, but do you think that they do have an effect on the Hill-Sachs lesion as well? Do you think that, for example, they do heal better or it doesn't make any difference?
Yeah, if we, still we are choosing the external rotation brace, but we cannot, healing. We cannot expect the healing of the bony lesion, even you choose the external rotation brace. We just expect the healing of the bunker lesion, of course. So if the patient has a large defect, glenoid defect, his lesion, maybe it's contraindication of the external rotation brace. And now we have an ongoing study that we used to perform the external rotation brace in the 0 degrees of abduction, but now slightly abducted, 30 degrees of abduction and the external rotation. Yeah, a little bit, slight abduction. Then we expect the, bunker region is shifted to more the superiorly, and we can expect more good healing. Now we are, ongoing study. Hopefully, 2 years and 3 years later, we can report about that. And we are still doing the external rotation brace. Don't forget the external rotation brace.
Thank you.
We'll never forget that. I still remember Professor Edgy demonstrating the different techniques of putting on the external. Professor, a little more question on to add on the spice of the topic. I think the hot cake of today's discussion is all subcritical bone loss, talking about mid-range instability. There are new procedures coming up every 6 months. A lot of procedures. We have a lot of excellent literature work and this thing. What is your take on all this? I mean, to be more specific, I'm asking you about DAS, dynamic anterior stabilization, or ASA, anterior subscapular as augmentation procedures, and putting the biceps there. And again, this is all kind of a procedure we are looking at for subcritical bone loss. Do you think, in your personal opinion as well, do you think these have a point, or we are just kind of still on an arbitrary basis on this?
Yeah, there are many kind of the procedure, but yeah, and I don't know the exact mechanism of those procedure. Maybe we need biomechanical the evidence, and but if you look at the clinical data in some paper, they reported a good clinical outcome. But we need to think about how much is the invasion that easy to do and what is the mechanism of those procedure, then we can choose. And of course, as I said before, we need to think about the two stability, end range and mid range. If the procedure have the good stabilized mechanism, both end range and mid range, it's a good procedure. And I performed a biomechanical study to clarify the mechanism of the lattice procedure. It has a good, reasonable, the stabilized mechanism, both at the end range and mid range. That's why I performed the lattice procedure.
Okay. Thank you, Prof. And going back to the mid-range instability, so do you feel that there is a significant correlation, because you did show in your graphs that the QL is actually associated more with that of the peripheral tract, but do you think that ligament laxity, obviously it's very difficult to quantify, that's the holy grail, but do you think that there is a correlation between the ligament laxity and that of a peripheral tract? Because peripheral tract, we are measuring it more on a static image, but obviously ligament laxity is more of a dynamic. And I've seen some of your papers where you actually measured, where you actually showed range of movements more with movement studies and that of the tract. But do you think that ligament laxity is something that can be correlated with that of a peripheral tract, and would that actually have a significant change in the way we would be actually managing these patients, the relationship?
Yeah, you are correct. Joint laxity is very much related to the stability. Also, when even though we think about the glenoid tract, we should consider the joint laxity also. And during my presentation, I said, the range of motion reflects the joint laxity. So that's why we investigate the relationship between glenoid tract and range of motion. But ideally, if there is the way we measure the quantitative ligament laxity, we want to do so. But so far, it's not easy to do so. So this time, we investigate the relationship between range of motion and joint laxity and the glenoid tract. But in the near future, if we have a good measurement method to quantitatively evaluate the joint laxity, that is ideal. Thank you.
Just to add on to that question, do you do capsule application like the posterior inferior capsule? So will you add that in these kind of mid-range instability patients? Would you do that?
Yeah, I do. Always, the before starting the surgery and the anesthesia, we compare the both sides. And if patient has a joint laxity, I add capsule application and anterior inferior capsule application. Or sometimes I add a rotator interval closure if patient has the joint laxity. In addition to, if you see the rotator interval elongation in the MRI image, I add a rotator interval closure.
Okay, thank you, Paul.
Thank you, Professor. I think rather than a question, I would take it as a point of learning. I mean, this is one thing that I've changed after meeting you in person as well, is individualizing the glenoid tracking. It just takes a 5 minute or rather 2 minute step. I've always seen you in the clinic measuring the horizontal extension of the contralateral shoulder, and that helps us whether to go to 83% or that I think makes a lot of difference. Like how our knee colleagues call it individualized ACLs. I think now we have the individualized glenoid tracks as well, just to measure the laxity. I mean, not the laxity, I mean the tracking calculation. And that makes a lot of difference to individualize the treatment protocol as well, I believe.
Okay, great.
I, just to add, what do you think? How do you feel that the further the future of the track would be? Where do you think dynamic MRIs, where like the spine, they started doing the dynamic MRI or flexion extension, they have these big gantries. So do you think that would be probably holding the answer to this, Professor?
Yeah, that's very good point. And our data is based on the static condition. Yeah, ideal is the dynamic condition. So, and also using the MRI dynamic condition, that is ideal. But still, yeah, it's difficult. But in the future, if we can do so, that's very much ideal. Yeah, thank you for your good, suggestion.
Yes, thank you.
I think we are slowly walking towards the end of the topic. We are not having much of questions. Since that, I'll again bother you with one last question of a case that I have in the next week. 19 years professor, Jiu-Jitsu, professional Jiu-Jitsu player who's having a bone loss of around 14%. And I did a Glenoid tracking as well. He comes under a peripheral track lesion. Of course, it comes under the contact sport. Would you still go ahead with a remplissage with a bankarts, or would you go with a letache? Sorry, this is a personal question. Don't
14,
mistake. 19 years,
for,
14%.
90 years
19
and
19 years.
okay, 19 and subclavicular bone loss
Yes.
and what kind of the dominant hand
It is also the
or
dominant hand,
sports?
right side. Right. He's
What kind of sport?
jiu-jitsu. He's part of the
Judo.
jiu-jitsu. He's part of the UAE into that young jiu-jitsu players as well.
Yeah, it's a kind of the contact athlete. So I
Yes.
prefer to perform the latter procedure. Of course, Bangal repair plus remplissage also one of option, but our data shows, you know, the recurrence rate is higher, 2 or 3 times higher compared to non-contact athlete. So these days we change the treatment strategy. We perform the latter procedure for contact athlete.
Thank you, Professor. That was my plan also. My only last thing is, for 19 years, should we worry about Latarjet, non-anatomical, and later on post-Latarjet arthritis and all those things? You worried, or we still are looking at safer picture?
Yeah, post-operative, osteoarthritis related to the position of the bone grafting and the screw back out. If we put the bone grafting correctly, we don't worry about the osteoarthritis. Now, many papers are reported about that. We don't worry about that.
So in a couple of days, I'll send you the image and you tell me put it right or wrong. Thank
I
you.
forgot to ask this question, but
Yeah.
this is one question. Is that, this is out of vogue because for a large hill sacks, would you ever consider putting a bone graft in position, Professor? Because this is something that, of a significant hill sacks lesion. We are not talking about like track but would you ever consider putting a bone graft in a large hill sacks lesion?
Yeah, actually, more than 20 years ago, I performed the bone grafting iliac crest to the large Hill-Sachs lesion, but it's invasive.
Yeah.
And if you think about the Glenoid track concept, and we perform the bone grafting to the glenoid, it means glenoid width increase, glenoid track width increase. We don't need to worry about the Hill-Sachs lesion. We don't touch the Hill-Sachs lesion. Just bone grafting to the glenoid. That's fine for large Hill-Sachs lesion. So these days we don't touch the Hill-Sachs lesion. That's my question. That's my the answer to your question.
And probably just to add on, the same thing would apply to a Latarjet. So if you actually can do a Latarjet procedure, increase the contact area, it converts it to an off track, and so you would not need to do a remplissage. Yes.
Yeah, right. That's correct. That's my strategy.
Okay. Thank you, Prof.
Thank you,
Thank
Professor.
you.
I think we would not keep troubling you with. We would love asking you questions, keep on asking you, learning from you, but we will not do that. Just for the fact, the time in place, Professor, where Japan is around 11 o'clock. So this shows his dedication, sitting at 11 o'clock and talking about glenoid tracking. I know him personally as well. For the audience who are really seeing it, he's a working bee. I've never seen speak too much, but he always keeps stick to academics. But one advice he'll give me till I remember, and my entire family remembers, before leaving out of Japan, is to do a proper balance between family and work.
Oh yes.
That is
That's very important.
that my entire family knows now.
Yeah. Yeah, you remember that.
No, I would never forget that.
Okay, good.
So
Excellent.
it's a huge pleasure and honor. Thank you, Professor. We want to see you soon. And I would also ask Dr. Senthil to convey his thank you.
Yeah. Thank you very much, Professor. It was really enlightening,
Yes,
and
thank you.
really happy to have all the questions answered. And we'd love to have you in person, but we'll definitely, let you well before in time so that you can make time for us to come to India again. Thank you very much, Professor, for
Yeah,
today.
Definitely, to at
thank you
least give
very
you
much.
spicy food.
Yeah, good.
Thank you, thank you.
Thank you.
And not at the least,
Thank
I would
you.
also like to thank you, Dr. Sendil, for his valuable time. He's one of the busiest surgeons from southern India, Chennai. And thank you. Though he's my good friend and senior colleague, but I really thank you. And also, not least, the platform Ortho TV, Rishi, and everyone who have been helping us. Without them, it is not possible. But definitely, thank you, Professor. We enjoyed the talk. I believe whoever's witnessed this, is going to witness this, is going to enjoy the talk. See you
Thank you.
soon, Japan, and
See you
Thank you
soon.
very
Thank
much,
you.
Karthik, and
thank you,
we will see you again with another edition of Shoulder TV series. Thank you.
thank you,
Thank
bro.
you.
Bye
Thank
bye.
you. Bye.
Good night. Thank you.
Good night.
Good night.